Hola, senors and senoritas. How are you? It's Professor Suresh, delighted to be back for my 37th video in pipeline for publication on YouTube today, 1st of July 2020. Topic for discussion today is multifarious manias, symptoms and treatment. Mania is a type of mood. Mania is usually a symptom of a medical problem or a mental illness. A person with mania is described as manic. The word mania comes from the Greek language. New words, alpha, VI, alpha means mania. The word comes from mainomai, which means to rage or to be furious, very angry. Mania is a symptom, not an illness by itself. Many different things can cause mania. These things include illegal drugs and brain tumors. However, most of the time mania happens in people with bipolar disorder. Bipolar disorder causes periods of mania that switch off with the periods of depression. Mania, also known as Manic Syndrome or manic episode, is a state of abnormally elevated arousal, affect and energy level, or a state of heightened overall activation with enhanced affective expression together with the liability of affect. The word mania stands for an excessive enthusiasm or desire for something. Most of us suffer from some obsession or other, but we may not have the word to describe our obsessions. Although mania is often conceived as a mirror image to depression, the heightened mood can be either euphoric or irritable. Indeed, as a mania intensifies, irritability can be more pronounced and result in anxiety or violence. The symptoms of mania include elevated mood, either euphoric or irritable, flight of ideas and pressure of speech, increased energy, decreased need and desire for sleep, and hyperactivity. They are most plainly evident in fully developed hypomanic states. However, in full-blown mania, they undergo progressively severe exacerbations and become more and more obscured by other signs, and majority of cases occur in the context of bipolar disorder. It is a key component of other psychiatric disorders such as schizoaffective disorder, bipolar type, and may also occur secondary to various general medical conditions such as multiple sclerosis. Certain medications may perpetuate a manic state. For example, prednisone or substances prone to abuse, especially stimulants such as caffeine. Coffee has a lot of caffeine, and cocaine. In the current DSM-5, hypomanic episodes are separated from the more severe full manic episodes, which in turn are characterized as either mild, moderate or severe with certain diagnostic criteria. Example, catanoia psychosis. Mania is divided into 3 stages: hypomania or stage 1, acute mania or stage 2, delirious mania, delirium or stage 3. The staging of a manic episode is useful from a descriptive and differential diagnostic point of view. Mania varies in intensity from mild mania, hypomania to delirious mania, marked by such symptoms as disorientation, florid psychosis, incoherence and catanoia. Standardized tools such as Altman's self-rating mania scale and Young mania rating scale can be used to measure severity of manic episodes, because mania and hypomania have also long been associated with creativity and artistic talent. It is nowadays a case that a clearly manic, hypomanic, bipolar patient needs or wants medical help. Such as persons often either retain sufficient self-control to function normally or are unaware that they have gone manic severely enough to be committed or to commit themselves. Manic persons often can be mistaken for being under the influence of drugs because the actions will be like that. In a mixed affective state, the individual, though meeting the general criteria for a hypomanic or manic episode, experiences 3 or more concurrent depressive symptoms. This has caused more speculation among clinicians that mania and depression, rather than constituting true polar opposites, are rather two dependent axes in a unipolar bipolar spectrum. A mixed affective state, especially with prominent manic symptoms, places a patient at a greater risk for completed suicide. Depression on its own is a risk factor, but when coupled with an increase in energy and goal-oriented activity, goal-directed activity, the patient is far more likely to act with violence or suicidal impulses. Hypomania, which means less than mania, is a lower state of mania that does little to impair the function or to decrease the quality of life. It may in fact increase productivity and creativity. In hypomania, there is less need for sleep and both goal-motivated behavior and metabolism increase. Some studies exploring brain metabolism in subjects with hypomania, however, did not find any conclusive link. While there are studies that reported abnormalities, some failed to detect differences. Though the elevated mood and energy level typical of hypomania could be seen as a benefit, true mania itself generally has many undesirable consequences, including suicidal tendencies, and hypomania can, if the prominent mood is irritable as opposed to euphoric, to be a rather unpleasant experience. In addition, the exaggerated case of hypomania can lead to problems. For instance, trait-based positivity for a person could make him more engaging and outgoing and cause him to have a positive outlook in life. When exaggerated in hypomania, however, such a person can display excessive optimism, grandiosity, and poor decision making, often with a little regard to the consequences. A single manic episode in the absence of secondary causes, that is, substance use disorders, pharmacologic or general medical conditions, is often sufficient to diagnose bipolar 1 disorder. Hypomania may be indicative of bipolar disorder. Manic episodes are often complicated by delusions and hallucinations, and if the psychotic features persist for duration significantly longer than the episode of typical mania, which is 2 weeks or more, a diagnosis of schizoaffective disorder is more appropriate. Certain obsessive compulsive spectrum disorders as well as impulse control disorders share the suffix mania, namely kleptomania, fear of water, pyromania, fear of fire, and trichotillomania. Despite the unfortunate association implied by the name, however, no connection exists between mania or bipolar disorder and these disorders. Furthermore, evidence indicates that a B12 deficiency can also cause symptoms characteristic of mania and psychosis. Hyperthyroidism can produce similar symptoms to those of mania, such as agitation, elevated mood, increased energy, hyperactivity, sleep disturbances, and sometimes, especially in severe cases, psychosis. To be classified as a manic episode, while the disturbed mood and an increase in goal-directed activity or energy is present, at least 3 or 4, if more, only irritability is present, of the following must have been consistently present: inflated self-esteem or grandiosity, decreased need for sleep, feels rested after 3 hours of sleep, for example, more talkative than usual or acts pressured to keep talking, flights of ideas or subjective experience that thoughts are racing, increase in goal-directed activity or psychomotor acceleration, distractibility, now too easily drawn to unimportant or irrelevant external stimuli, excessive involvement in activities with a high likelihood of painful consequences. Example, extravagant shopping, improbable commercial schemes, hypersexuality, etc. Though the activities one participates in while a manic state are not always negative, those with the potential to have negative outcomes are far more likely. If the person is concurrently depressed, they are said to be having a mixed episode. A person experiencing mania or a manic episode may present with the following symptoms: elevated mood, increased energy and overactivity, hyperactivity, reduced need for sleep or food, irritability, rapid thinking and speech, and grandiose plans and beliefs, lack of insight, distractibility. A person may experience mania as a result of range of factors including stressful events, genetic factors, biochemical factors, neurotransmitter abnormalities or imbalance, seasonal influences. Bipolar affective disorder, shortly BPAD. For individuals living with bipolar affective disorder, also called bipolar disorder and formerly called manic depressive psychosis, they will experience recurrent episodes of depression and mania, of which the symptoms are not due to substance use or other, substance means drugs if you do not know, or other general medical conditions. The manic or depressive episodes are usually separated by lengthy periods where the person is well. The average age for the first manic episodes is in the early 20s. However, some episodes begin in adolescence. The first episode rarely occurs after the age of 50. Manic episodes in adolescence are more likely to include psychotic features and may be associated with the school truancy, antisocial behavior, school failure, or substance abuse. Lifetime prevalence is about 1%. Manic episodes begin suddenly and with a rapid escalation of symptoms over a few days. They may follow psychosocial stressors or a major depressive episodes. Symptoms similar to those in a manic phase may be due to the effects of antidepressant medication. Electroconvulsive therapy or medication prescribed for other physical illnesses, for example, corticosteroids, and are not included in the diagnostic category. Nurses who have worked with people who have mania have reported the following reactions: amusement, irritation, embarrassment, and discomfort. The World Health Organization, WHO, shortly WHO, classification system defines a manic episode as one where mood is higher than the person's situation warrants and may vary from relaxed high spirits to barely controllable exuberance, is accompanied by hyperactivity, a compulsion to speak, a reduced sleep requirement, difficulty sustaining attention, and are often increased distractibility. Frequently, confidence and self-esteem are excessively enlarged and grand extravagant ideas are expressed. Behavior that is out of character and risky, foolish, or inappropriate may result from a loss of normal social restraint. Some people also have physical symptoms such as sweating, pacing, and weight loss. In full-blown mania, often the manic person will feel as though his or her goals are of paramount importance, that there are no consequences or the negative consequences would be minimal, and that they need not exercise restraint in the pursuit of what they are after. They try to justify their actions. It is internal, of course. Hypomania is different, as it may cause little or no impairment to function. Low. Hypo means low. The hypomanic person's connection with the external world and its standards of interaction remain intact, although intensity of moods is heightened. But those who suffer from prolonged unresolved hypomania do run the risk of developing full mania, and indeed may cross that line without even realizing they have done so. One of the signature symptoms of mania, and to a lesser extent hypomania, is what? Remains intact, although intensity of moods is heightened. For those who suffer from prolonged hypomania run the risk of developing full mania, and indeed they may cross the line. Racing thoughts is one of the main symptoms. These are usually instances in which manic person is excessively distracted by objectively unimportant stimuli. This experience creates absent-mindedness, where the manic individual's thoughts totally preoccupy him or her, making him or her unable to keep track of time or be aware of anything besides the flow of thoughts. Racing thoughts also interfere with the ability to fall asleep. Manic states are always relative to the normal state of intensity of the afflicted individual. Thus, already irritable patients may find themselves losing their tempers even more quickly, and an academically gifted person may, during the hypomanic stage, adopt seemingly genius characteristics and an ability to perform and articulate at a level far beyond that which they would be capable of during euthymia. A very simple indicator of a manic state would be if a heretofore clinically depressed patient suddenly becomes inordinately energetic, enthusiastic, cheerful, aggressive, or over happy. Often, less obvious elements of mania include delusions, generally of either grandeur or persecution, according to whether the predominant mood is euphoric or irritable, hypersensitivity, hypervigilance, hypersexuality, hyperreligiosity, hyperactivity, and impulsivity, a compulsion to over-explain, typically accompanied by pressure of speech, grandiose schemes and ideas, and a decreased need for sleep. For example, feeling rested after only 3 or 4 hours of sleep, as I said before. In the case of the latter, the eyes of such patients may both look and seem abnormally wide open, rarely blinking, and may contribute to some clinicians' erroneous belief that these patients are under the influence of a stimulant drug. People that abuse the substances, their eyeballs, the pupa will bulge out from the sockets. So it can be wrongly diagnosed when the patient in fact is either not on any mind-altering substances or is actually on a depressant drug. Individuals may also engage in out-of-character behavior during the episode, such as questionable business transactions, wasteful expenditures of money, example spending sprees, risky sexual activity, abuse of recreational substances, excessive gambling, reckless behavior, such as extreme speeding or other daredevil activity, abnormal social interaction, example over familiarity and conversing with the strangers, or highly vocal arguments. These behaviors may increase stress in personal relationships, lead to problems at work, and increase the risk of altercations with the law enforcement. It is happening to a large extent because of the lockdown. So many youngsters argue with the police and all that. There is a high risk of impulsively taking part in activities potentially harmful to the self and others. Various triggers have been associated with the switching from euthymic depressed states into mania. One common trigger of mania is antidepressant therapy. Studies show that the risk of switching while on an antidepressant is between 6 to 69%. Dopaminergic drugs such as rapid reuptake inhibitors and dopamine agonists may also increase the risk of switch. Other medications possibly include glutaminergic agents and drugs that alter the HPA axis polarity. Lifestyle triggers include irregular sleep-wake schedules and sleep deprivation, as well as extremely emotional or stressful stimuli. Mania may be associated with strokes, especially cerebral lesions in the right hemisphere. Deep brain stimulation of the subthalamic nucleus in Parkinson's disease has been associated with mania, especially with electrodes placed in the ventromedial STM. A proposed mechanism involves increased excitatory input from the STM to dopaminergic nuclei. Mania can also be caused by physical trauma or illness. When the causes are physical, it is called secondary mania. There are several disorders with the Manic Syndrome: organic manic disorder, mania without psychotic symptoms, mania with the psychotic symptoms, other manic episodes, unspecified manic episodes, manic type of schizoaffective disorder, bipolar affective disorder, current episode manic without psychotic symptoms, bipolar affective disorder, current episode manic with the psychotic symptoms. Before beginning the treatment for mania, careful differential diagnosis must be performed to rule out secondary causes. The acute treatment of manic episode of bipolar disorder involves the utilization of either a mood stabilizer like valproate, lithium, lamotrigine, or carbamazepine, or an atypical antipsychotic, olanzapine, quetiapine, risperidone, or aripiprazole. Although hypomanic episodes may respond to a mood stabilizer alone, full-blown episodes are treated with an atypical Antipsychotic, often in conjunction with a mood stabilizer, as these tend to produce the most rapid improvement. When the manic behaviors are gone, long-term treatment then focuses on prophylactic treatment to try to stabilize the patient's mood, typically through a combination of pharmacotherapy and psychotherapy. The likelihood of having a relapse is very high for those who have experienced 2 or more episodes of mania or depression. Bipolar disorder, also known as manic depression, is a mental health problem that causes extreme changes in mood. If you have bipolar disorder, you may sometimes feel excessively elated, impulsive, irritable, or irrational, called mania, or hypomanic, a milder form of mania. Other times you may feel excessively sad, called major depression. Bipolar disorder, mood swings, you can see. Bipolar disorder can make it hard to do a good job at work or school, have relationship with the friends and family, and it even increases the risk of suicide if it is not treated or treated incorrectly. However, a number of effective treatment options are available. For many reasons, it may take many years to diagnose bipolar disorder. As an example, a person may have multiple episodes of depression before an episode of hypomania or mania. The exact cause of bipolar disorder is not clear even today. The problem may be related to an imbalance of chemicals in the brain. These chemicals allow cells to communicate with each other and plays an essential role in all brain functions, including movement, sensation, memory, and emotions. Approximately 1 to 3% of people worldwide have bipolar disorder. People with a family history of bipolar disorder are at increased risk of developing the condition. Most people develop the first symptoms of bipolar disorder at a young age, especially when they are an adolescent, between the ages 15 to 30 years. It is uncommon to develop the first symptoms of bipolar as a child or as an adult over the age of 65. More than 60% of people with the bipolar disorder abuse alcohol or drugs. The risk of suicide also is higher in people with the bipolar disorder compared to people with other psychiatric illnesses, including depression. Suicide is often the result of feeling hopeless. It's a momentary feeling. Treatment of mania focuses on managing symptoms and keeping you safe. The early phase of mania, called the acute phase, you may be psychotic, having false, fixed beliefs, or hearing voices, or seeing things others cannot see or hear. You may not be able to make good decisions, and you may be at risk of hurting yourself or others. You may need to be treated in a hospital temporarily until your medicine begins to work. While medication for bipolar disorder is important to manage symptoms of mania and depression, studies show relying on medication alone is not the most effective method of treatment. Medication is most effective when used in combination with other bipolar disorder treatments, including psychotherapy, self-help coping strategies, and healthy lifestyle choices. Antipsychotic medicines are often used first in the treatment of mania. Once the worst symptoms of mania or depression are under control, treatment focuses on preventing the recurrence. People who have suffered a manic episode are often advised to continue taking medicines to control bipolar disorder. This usually involves a single mood stabilizing medicine such as lithium. Lithium is very effective, or valproate. Although medicines are the treatment of choice for bipolar disorder, counseling and talk therapy also have an important role in treatment. This is especially true after an acute episode has passed. Psychotherapy may include individual counseling as well as education, marital and family therapy, or treatment of alcohol and or drug abuse. Therapy can also help you to stick with your medicine, which can decrease the risk of a relapse and the need for hospitalization. Lithium is a classic mood stabilizer to prevent further manic and depressive episodes. A systematic review found that the long-term lithium treatment substantially reduces the risk of bipolar manic relapse by about 42%. Anticonvulsants such as valproate, oxcarbazepine, and carbamazepine are also used for prophylaxis. More recent drug solutions include lamotrigine and topiramate, both anticonvulsants as well. In some cases, long-acting benzodiazepines, particularly clonazepam, are used after other options are exhausted. In more urgent circumstances, such as in emergency rooms lorazepam has been used to promptly alleviate symptoms of agitation, aggression, and psychosis. Sometimes typical antipsychotics are used in combination with the previous mentioned medications as well, including olanzapine, which helps treat hallucinations and delusions, azanapine, aripiprazole, risperidone, ziprasidone, and clozapine, which is often used for people who do not respond to lithium and anticonvulsants. Verapamil, a calcium channel blocker, is useful in the treatment of hypomania and in those cases where lithium and mood stabilizers are contradicted or ineffective. Verapamil is effective for both short-term and long-term treatment. Antidepressant immunotherapy is not recommended for the treatment of depression in patients with bipolar disorders 1 and 2, and no benefit has been demonstrated by combining antidepressants like Prozac with mood stabilizers in these patients. Some atypical antidepressants, however, such as mirtazapine and trazodone, have been occasionally used after other options have failed. The time to relax is when you don't have the time for it. Attributed to both Jim Goodwin and Sidney J. Harris. So when you are stressed, one has to relax really. Don't take any hasty decisions. Relaxation skills address anxiety from the standpoint of the body by reducing the muscle tension, slowing down breathing, and calming the mind. Relaxation skills can be structured. Examples are slow diaphragmatic breathing, meditation, and yoga. Other factors such as self-care and enjoying pleasurable activities are also helpful to make us feel more relaxed. In this module, we'll explore some of these strategies, explaining how they are used and how they work, why they work. Relaxation strategies are best suited as a companion to exposure and cognitive skills, but not as a replacement to them. Overall, for all kinds of illnesses and disorders, yoga and meditation have significant positive effects. Family support and psychological counseling are also very much essential. Medication should be the last resort, especially allopathy. It's all chemical compounds which has some other adverse effects. Debates, discussions on topics like this can go on forever. Anyhow, let me call it a day. We'll meet again real soon. Rest in peace and harmony. Always watch these videos with closed captions, subtitles for absolute 100% comprehension as per my persistent recommendation. I know I rushed through to complete the presentation within 20 minutes max. There's a time limit I had set myself to retain the viewer's attention as a norm. I know nowadays I exceed these time limits since I make honest attempts to cover the selected topics more elaborately, including so many intricate fine details, referring a wide variety of sources, in particular Wikipedia quite extensively, besides articles and books published recently. Besides, I had my own masala based on my personal experiences so far in my life and intuition also. Stay at home as much as possible to maintain social distancing, attributed to pandemic novel COVID-19, and prolong your lifespan. Lead a healthy life. God alone can put a stop to natural, unnatural, maybe bio-war and cyber-war events like pandemics, which may lead to apocalypse and extinction of all sentient species on Earth. All the best.